Module 4, Chapter 27, Anger, Aggression, and Violence. Our objectives are to define anger, aggression, and violence, identify biological and cognitive risk factors for increased anger, aggression, and violent feelings and behaviors. Anger, aggression, and violence. Anger is an emotional response to frustration of desires, threat to one's emotional and physical needs, or a challenge. Aggression acts on behavior that results in verbal or physical attack. Aggression tends to be used synonymously with violence. However, aggression is not always inappropriate and is sometimes necessary for self-protection. On the other hand, violence is always an objectionable act that involves intentional use of force that results in or has the potential to result in injury of another person. So in that, I have defined violence at the same time when I talk to you about aggression. The violence is an objectable act that involves intentional use of force that results in or has potential to result in injury of another person. This is our case study for this chapter. Your new patient, Mr. Otis, is assigned to your unit after getting into a fight outside a family restaurant. He got into an argument with a family saying they threatened him, but witnesses were able to attest that the family had, in fact, said nothing to him at all and had, until he approached them in anger, barely noticed him in the parking lot. Mr. Otis is a veteran with a history of post-traumatic stress disorder, PTSD, and comorbidities of depression and intermittent psychotic episodes. He does not appear to have a substance abuse disorder. Epidemiology. In the hospital, violence is most frequently found in the emergency department, psychiatric units, geriatric units, and intensive care units. It's likely that you'll need to manage violent behavior at some point in your career. Nurses are frequent targets of violence because they have the most direct client contact. Violence can occur anywhere in the hospital, but it's most frequently in the units that I discussed in the PowerPoint. They're also overly present in clients and clients' significant other attacks. So you have the disadvantage of being in a position where you hold the key that can bring on violence. Comorbidities, PTSD, substance use disorders, coexistent with bipolar disorder, anger and hostility are risk factors for chronic illness and may be predictive of hospitalizations for multiple chronic illnesses like hypertension and cardiovascular disease. There's a higher prevalence of inflammation and chronic illness in older adults. Your risk factors are going to be a biological factor. There's genetic predisposition, neurobiology, brain injury or abnormalities, and neurotransmitters. Cognitive factors like behavioral theory or learned responses and social learning theory that imitate others. Early behaviorists believe that emotions, including anger, were learned responses to emotional stimuli. The stimulus is often a perceived threat, and this perception, leads to the emotional and psychological arousal necessary to act. Although the threats is usually understood as an alert to physical danger, noted that other threats in areas such as values, beliefs, moral conduct could also lead to anger. Social learning. Researchers demonstrated that children learn aggression by observing and imitating others, especially if that behavior is rewarded. Thus, children who watch television violence and experience violence in the home learn aggressive ways to resolving problems. Application of the nursing process. Objectives. Discuss 3 types of assessment questions and their value in the nursing process. Compare and contrast interventions for a client with a healthy coping skill with those for a client with marginal coping skills. Apply at least 4 principles of de-escalation with a moderately angry patient. We're going to describe 2 criteria that make the use of seclusion or restraint more appropriate than verbal intervention. Role play with classmates using understandable and unhelpful responses to anger and aggression in clients. And role play the classmates using helpful responses to anger and aggression in clients. Application of the nursing process assessment. You always need to do a general assessment of a patient, trauma-informed care, and self-assessment. Trauma-informed care is an older concept of providing care that has recently been reintroduced. It is based on the notion that disruptive patients often have histories that include violence and victimization. These traumatic histories can impede clients' ability to self-soothe and result in negative coping responses and create a vulnerability to coercive interventions like restraint by staff. Back to our case study. In the unit, Mr. Otis's paranoia continues and he becomes agitated and threatens to assault another staff person. He tells you, "You're the only one I think I can trust, but can I? Are you going to take their side?" Select the best initial intervention for Mr. Otis at this point. A, say if you do not calm down, seclusion will be needed. B, address him with simple direction and a calming voice. C, help him focus by rubbing his shoulders. D, offer him a dose of antipsychotic medication. The answer is B. A calming voice and simple non-emotional direction can help de-escalate a client's anxiety. This is an initial intervention, so do not threaten him with seclusion or resort to antipsychotics. Rubbing his shoulder is inappropriate and may contribute to anxiety, not calm him. A new nurse asks a coworker which clients are most likely to become aggressive or angry. What are some risk factors that may predict violent behavior? Well, we can think about this in terms of a history of violence. Excuse me. A history of violence is the single best predictor of future violence. If they've done it once, they'll do it again, most likely. Clients who are delusional, hyperactive, impulsive, or predisposed to irritability are at high risk for violence. Major factors associated with violence can be assessed with these questions. Does the client have a wish or intent to harm? Does the client have a plan? Does the client have means available to carry out the plan? And does the client have demographic risk factors like risk factors being male, ages 14 to 24, low socioeconomic status, inadequate support system, prison time, things like that? Aggression by clients occurs most often in the context of limit setting by the nurse. And history of limited coping skills, including lack of assertiveness or use of intimidation, indicates a higher risk of using violence. Like clients, nurses have their own histories. The nurse's ability to intervene effectively depends on self-awareness of strengths, needs, concerns, and vulnerabilities. Without this awareness, nursing interventions can end up being impulsive or emotionally based responses. Self-awareness includes recognizing choice of words and tone of voice, as well as nonverbal communication through body posture and facial expressions. In the nursing process, nursing diagnosis, you have a risk for violence, a risk for suicide, difficulty coping, stress overload, and impaired impulse control. Outcome identification, if you look at table 27.1 in your book, we're going to talk about planning, implementation, general interventions, health teaching and health promotion, teamwork and safety, the use of seclusion and restraints, and evaluation. There's 6 basic considerations for ensuring safety. Avoid wearing dangling earrings, necklaces, and scarves in acute care environments. The client may become focused on these and grab at them, causing serious injury to you. Ensure that there's enough staff for backup. Only one person should talk to the patient. Remember when I said one voice? But staff need to maintain an unobtrusive presence in case of the situation escalates. Always know the layout of the area. Correct placement of furniture and elimination of obstacles or hazards are important to prevent injury, and the client requires physical interventions. Do not stand directly in front of the client or in the front of the doorway. The client may consider this position as confrontational. It's better to stand off to the side and encourage the client to have a seat. If a client's behavior begins to escalate, provide feedback. You seem very upset. Such an observation allows exploration of the client's feelings and may lead to de-escalation of the situation. Avoid confrontation with the client, either through verbal means or through a show of support with security guards. Verbal confrontation and discussion of the incident must occur when the client is calm. A show of force by security guards may serve to escalate the client's behavior. Security personnel are better kept in the background until they are needed to assist. Mr. Otis becomes increasingly agitated, and when you come back from break, you find he wants to talk to you alone. Your response is A, respect his privacy and see him alone. B, do not speak to him in private. It's time for the team to confront him calmingly as a group. Ask for him to put in restraints first or take security staff with you. D, Go speak to him in a non-confrontational way, but ensure that there is other staff nearby for backup. The answer is D. Ensure that there's enough staff for backup. Only one person should talk to the client, but staff needs to maintain an unobtrusive presence in case the situation escalates. Avoid confrontation with the client either through verbal means or through a show of force with security guards. Verbal confrontation and discussion of the incident must occur when the client's calm. A show of force by security guards may serve to escalate the client's behavior. Therefore, security personnel are better kept in the background until they are needed to assist. Seclusion or restraints. Seclusion is the involuntary confinement of a client alone in a room or area from which the client is physically prevented from leaving. Restraint is any manual method, physical or mechanical device, material or equipment that immobilizes or reduces the ability of a client to move his or her arms, legs, body, or head freely. The goal of seclusion is never punitive. Rather, the goal of seclusion is safety of the client and others. Seclusion is less restrictive than restraint and may be helpful in reducing sensory overstimulation. There are several contraindications for the use of seclusion and restraint. Clients who have extremely unstable medical or psychiatric conditions are not considered safe candidates for these treatments. Chronic obstructive pulmonary disease, spinal injury, seizure disorder, and pregnancy are examples of contraindicated problems. Delirium and dementia may make seclusion and restraint intolerable due to the absence of stimuli. The restrictive measures should be avoided in clients who are overly suicidal and those who require monitoring for severe drug reactions and overdoses. There are guidelines for the use of mechanical restraints, indications for use, legal requirements, documentation requirements, clinical assessments, observation, release procedure, and restraint tips. You can see all of these in box 27.3 in your book. Mr. Otis becomes violent and must be placed in restraints. What questions need to be asked after this incident? Could we have done anything that would have prevented this episode? If yes, what could we have done and why was it not done in this situation? Did the team respond as a team? Were team members acting according to policy and procedure of the unit? If not, then why not? How did staff members feel about this client, about this situation? Feelings of fear and anger, disgust, and handled. Employee morale, productivity, use of sick leave time, transfer requests, and absenteeism are all affected by client's violence, especially if a staff member has been injured. Staff members must feel supported by their peers as well as by the organizational policies and procedures established to maintain a safe environment. Is there a need for additional staff education regarding how to respond to violent patients? How did the actual restraining process go? What could be done differently? Do not focus only on whether the staff was acting like a team. If injury occurred, has it been reported and cared for? It has been shown that there is a vast underreporting of violence against healthcare staff. Treatment modalities and intervening with special populations. Treatment modalities can be pharmacotherapy, anger, aggression, and violence in general hospital settings, clients with healthy coping skills who are overwhelmed, clients with marginal coping skills, and clients with cognitive deficits need to be recognized in these settings. Finally, Mr. Otis is restrained. As his nurse, what is your first priority? A. Debrief the patient. B. Ensure the patient's safety. C. Administer a sedating medication. Or D. Obtain an order from a healthcare provider. The answer is B. Once in restraint, a client must be directly observed and formally assessed at frequent, regular intervals for a level of awareness, level of activity, safety within restraints, hydration, toileting needs, nutrition, and comfort. Which client behavior is a criteria for mechanical restraint? A. Screaming profanities. B. Assaulting a staff person. C. Refusing a medication dose. D. Throwing a pill at another patient. The answer is B. Indications for the use of mechanical restraint include protecting the patient from self-harm and preventing the patient from assaulting others.